So I'm going to start off by talking about what I hope you'll gain from this talk, which is, and I should say, my specialty in research has been medical decision-making. And when I was at Stanford, we developed clinical prediction rules for estimating the probability that a patient with chest pain would end up having a positive coronary arteriogram and other things like that. So that's what I'm coming from. So what I'd like you to think about is a framework for making treatment decisions when you're uncertain about the diagnosis, decision-making under uncertainty. What you start is by characterizing your uncertainty with a number, a probability. I'm going to point out, hopefully make the case convincingly, that decisions involve trade-offs between treatment harms and treatment benefits, and that these trade-offs change as the probability of disease changes. So it really makes it pretty complicated to see where you are. And finally, the treatment threshold probability is something that simplifies the no-treat decision. Then we'll talk about an application of this model to a familiar topic to all of us, which is suspected PE. And I'm going to talk a little bit about a problem and how it could be overcome by using computer-based support as an educational tool, as well as something to guide patient care. So I start off with this challenging remark, and I hope we'll get a few people who will be nodding their heads about this. And why is decision-making not taught systematically? Well, for one thing, it occurs in small groups taught by a single teacher, and those teachers vary a lot in their skill set. We know that if we look within ourselves. And I'm going to make the proposal that by using the computer to help guide people through the evaluation and decision treatment, they can learn without having to depend on their attending being a real expert on probability theory and so forth, like I was. Okay, so we're going to start off by talking about a model that's going to be kind of dry. I may stumble a little bit, and then we're going to talk about PE, which I know a bit about. I should mention, I've given grand rounds here when I left Stanford in 1988 to go to Dartmouth. I talked about pulmonary embolism. My dad was in the audience for that. I came back when I left Stanford to go to Annals and was invited to be a visiting professor by Mike Jacobs and others. Again, I talked about pulmonary embolism. But as I look out here, I see only a few people who've heard either one of these talks. So I think I'm safe. All right. So MD Calc, it's if you don't know that, it's a collection of clinical prediction rules for estimating probability, and it's on your cell phone, and if it isn't, it should be. And I see this as sort of a simple approach to decision making. It's a start, but it's a model to see it actually on your cell phone. It's really cool. So let's now kind of think about what it's like to care for a patient that we're just not sure what's going on. So you start by estimating the patient's probability. The way that most of us do it, to the extent that we do it at all, is to pull a number out of the air that somehow is between 0 and 1, and it characterizes our sense of what's going on with the patient. Or you could use a clinical prediction model, MD Calc, or you could start with a clinical prediction model and then vary your probability depending on specific circumstances. The 35-year-old man with chest pain that you say, well, this guy's got about a 2% chance of coronary disease, until you ask the question that, well, what about your family history? And find out that his brothers all died in their 30s from coronary disease. So the next step after getting a probability is decide what to do. Low probability, just observe. High probability, start treatment now. And intermediate probability, get more information. Now we're going to talk about probability, and I entitled this slide, Getting Concrete About Probability, what it actually means. And each one of the open circles is somebody without the target condition, and the closed circles are people with the target condition. So the probability of disease, as it gets higher, more and more people are going to have the target condition. And each one of these probabilities is going to have its own mix of the benefits and harms of treatment. So it gets complicated pretty quickly, and we're going to try to tackle that. So here are some generic outcomes for what happens when disease is present and you treat or don't treat when disease is absent, when you treat and what you don't treat. And I'd argue that at any given probability, a patient faces a mix of these two. And I hope I made that point clearly. And that probably for people who have the disease, or for people who are treated, their treatment is weighted by their probability of disease. And if people don't have the target condition, their treatment is weighted by, the outcomes are weighted by I'm lost here. Yeah. I'm going in the wrong direction, folks. There we go. So we could, in principle, make a calculation of the patient's expected outcomes for each one of these probabilities. That would be complicated, and it'd be a lot of work. And the question is, would that help us to decide when to treat and when not to treat? And I'd argue that it probably, the juice is not worth that squeeze. So in fact, I'm going to argue that if you know the probability of disease and you know something called the treatment threshold probability, you're golden. So here what we've done is to plot the net benefit of treatment or withdrawing treatment, not treating, against the probability of disease. Think of the benefit as lifetime in healthy, in good health. Think of the benefit of not treating as avoiding being treated to something that would be harmful to you if you were treated. It's a little complicated, but I think it's good reasoning. And so here's the treatment threshold probability. It's where the two lines intersect and where the expected benefits are the same for both treatment and not treatment. So pretty obvious, if the probability is below that threshold, you don't treat. And if the probability is above, you do treat. So if you know the treatment threshold and your own probability, you're done. Unless, of course, you decide to do a test. And that's what we come to next. So why do a test? Well, in the framework we're trying to develop, the test result could change your probability from below the treatment threshold to above the treatment threshold so that you would actually do something different as a result of the test result. How do you calculate the change in probability? You use something called Bayes' theorem that shouldn't be a mystery to anybody in this room, but unfortunately, I'm not betting on it. But it requires the sensitivity and specificity of the test, which requires really good science to get it right and avoid bias, as well as the pretest probability, like MD Calc. And just as a reminder, the dark circle on the left is the pretest probability. The arrow on the right is the post-test probability. And the length of that arrow tells you how much the probability changes. And that's where Bayes' theorem does its thing. So we're going to now start by focusing on choosing between two tests. With test one, if it's positive, you know more about the patient, but you're still not going to treat the patient if you believe in the treatment threshold having some important meaning. But with test two, you clearly would be inclined to do that test, because if it was positive, you'd be surprised and you'd treat despite your surprise. And of course, the same reasoning works from the other direction for high pretest probabilities. So we've just talked about how the treatment threshold can help you choose between two tests. Well, now we're going to focus on a different problem. So suppose you know the treatment threshold probability, which I'm going to call it P star, so we don't prolong this talk unnecessarily. The patient's probability of disease, PD. You know about a potentially useful test, and you know its sensitivity and specificity. And the question is, do you do the test or not? And I think this will help us. With the top one of these arrows, we're not going to do the test because it won't cross the treatment threshold. In the second one, we will do the test because it's going to cross the treatment threshold. And in the third one, the post-test probability just makes the treatment threshold. And so that's the marks the point at which, below which, you're not going to be able to change the probability enough to change the treatment. And so you should observe. So there's a zone of probabilities where you should be thinking about just follow the patient closely and don't do anything. Same reasoning going in the other direction. And so you end up with this nifty model, which divides the probability between an observed range, a test range where the test can make a difference, and a treat range. We're going to come back to this when we get into the weeds of pulmonary embolism. So we're now at an inflection point in this talk, and it's going to not be dry stuff about probabilistic models. It's going to be dealing with something that we all enjoy talking about. So PE, still dangerous, kills a lot of people every year, and often we start treatment when we're not sure of the diagnosis. We don't wait for a pulmonary angiogram because that's expensive and dangerous, and nobody will come in to do it in the middle of the night. So easy going so far, but now we're going to get down into the weeds. Figuring out the treatment threshold probability is really a tough problem here. The modeling strategy is pretty simple. You try to find the probability of disease where one action and the other action are equivalent, that they have equal value. So, for example, when the utility of treatment equals the utility of no treatment, you've got a treatment threshold. And the same kind of reasoning would apply to testing versus not doing anything, or testing versus starting treatment without testing. So in the next slide, I'm going to represent this decision problem with a decision tree. But because we don't have all day for me to describe it, we're going to view it from a very safe distance, and we're not going into the weeds at all. But I actually represented this thing on a spreadsheet and did a lot of work with that. So there it is. Okay, folks, that's enough. No peeking. All right. So here's some of the probabilities that goes into that model. Death with treatment for PE, there's some excellent systematic reviews, and the number I picked was 3% for hospitalized patients. And intracranial hemorrhage due to anticoagulation, lots of studies of that, and the number I'm representing is 1%, probably lower than that, but that's what I chose. So the one that's tough, and the one that you guys are all gonna have to struggle with, is what's the probability of death without treating PE? And the reason is we don't have any contemporary knowledge of that. Back when I was in high school, they did randomized trials comparing treatment with anticoagulation with no treatment. And they found that the death rate in the control group was 25 to 30%. So that's a number, but that's a number that applies to a different era in the care of very, very sick patients. So we're kind of in trouble there, because nowadays everybody with PE gets treated. So we're going to have to estimate that probability of death without treatment by some sort of subjective process. Here's some of the predictors of death from PE, and those are probably predictors that would also apply to death if you weren't treated, and you can see what they are there. So this slide's important. It's a graph where the horizontal axis is the hypothesized death rate without treatment, and the vertical axis is the treatment threshold probability. What this is really telling us is there's no single treatment threshold probability, at least for PE. It really depends upon, among other things, but most importantly upon the hypothesized mortality for death without any treatment for PE. So that's kind of the soft point in this, but it's also gives us an opportunity to have a good conversation about how to deal with that. So for the purpose of the example that I'm going to describe now, I picked a 10% mortality for untreated PE. So that's 3 times the mortality of treated PE. And I don't know whether you think that's too low or too high, but this is not the time for us to talk about that. And that gives us a treatment threshold probability of 12%. And I'm going to use percent because it's to represent probability, which some people would be cross about, but hopefully nobody here. Okay, so just a reminder about our model. Low probability observed, intermediate probability test, high probability treat without testing. And we're going to come back to this in the specifics of pulmonary embolism. So just to kind of catch our breaths here, we've seen how to apply a treatment threshold probability to guide testing and treatment decisions with suspected PEs. You can see how it's going to unfold. So what I want you to do is to imagine the next few slides as taken from a computer-based decision model that has all kinds of bells and whistles attached to it, but the basics are what we're going to see here. And that's something that a student could follow and learn from how to manage PE and how to think about decision-making under uncertainty. So first step, is to formulate a pretest probability. So you suspect PE, and so you estimate a probability of PE with something called the Weld score, which you can take this one to the bank. It's been studied and studied and studied. And the version that I'm showing actually has all the weights being +1. And based, if you have 0 or 1, your probability is 11%. If you have 2 or more, your probability is 37%. This is really quite solid, and you can see it in MD Calc. So you suspect PE, you estimate the PE with a Weld score, it's +1, your probability is 11%. What next? Do you do a D-dimer, or do you just start treatment, or do you tell the patient, you know, call me in the morning if you're not better? Well, let's talk about that. The threshold, there's a, what this shows is the threshold probability for doing a D-dimer given a specific treatment threshold, which is 12%. And it's as low as 7% and as high as 55%. And for those of you who are not physicians, this is what a D-dimer is. So there's our model, come back again, but now with some numbers that have some reality. So the test zone for D-dimer is represented in light green. Your pretest probability is, which is 11%, just below the treatment threshold of 12%, which is represented in red. So the test zone, the probability is in the test zone, so you should be doing a D-dimer. After all, if it's negative, the probability is going to be hopefully low enough so you really can tell the patient to call me if you're not better in the morning. So, but in this case, the D-dimer was positive. And the probability goes from 11% to 17%. It's a reminder that the D-dimer is a very nonspecific test. It doesn't raise probabilities much, but it's very sensitive, and it really drives probabilities downwards in a very good way. So the next step, possibly do a CTPA. And for those of you who are not physicians, I've written a little bit about what a CTPA is. It's basically an angiogram done with a CT scanner, and it's a pretty good test. We'll see here, sensitivity 83%, and really hot, very high specificity. And these numbers may be even better now because our scanners have gotten better since this major national trial that was published a number of years ago. So the test zone is very broad. And with our post-test probability after the D-dimer, we're right in the middle of the test zone for CTPA, so we should do it. The CTPA is positive. Probability of PE is 88%. So obviously we're going to be treating this patient. If it had been negative, the post-test probability would have been about 3.5%. Now, that's not 0. It's not even 1%. It's 3.5%. But if there are no other tests to be done, then the patients can be better off if you don't test them, if you don't treat them, because 3.5% is below the treatment threshold probability of 12%. So we're almost done. Before we stop, I want to give this very simplified version of how to estimate the treatment threshold probability. And this can be calculated, this can be derived, harms over harms plus benefits. Now, most of the time, we do treatments in which the harms are considerably lower than the benefits. They're certainly not 50-50. And so most of the time, the treatment threshold is going to be below 50%. So a few last thoughts. How can we expose all of our students to a uniformly high standard of teaching about decision-making under uncertainty? So I've listed some pretty easy steps that really anybody in this room could do in their teaching. But it starts with the hardest of all, which is to add a lecture to the curriculum on the subject. Supposed to be a laugh there now. Don't you guys work at a medical school? And a decision, and what I've done is to show that a decision model can help us to make patient-specific recommendations based on the characteristics of the patient in determining the pretest probability and the like. But decision models are for computers, not for individual physicians at the bedside. So let the student learn from the model. Thanks, I enjoyed it. A little bit of time for questions. All done.
Dr. Singh first.
Hi, good morning. That was great. Can you hear me? Yeah. Because the interns are here, I'm going to ask a provocative question to your provocative lecture, which is I love the science and I love being able to break it down into A, B, C, D, but where in all this do we put in like the gut feel, right? We all talk as physicians about your gut response to a patient when you walk in, about how they look and what your response is. So how and when should that be something that we teach or think about? And I think especially for the trainees, I think it's really important to hear your perspective on that. Thank you.
So the question is, how do you factor your gut feeling when you first see the patient into this? Well, one approach would be to try to turn that into a number, a probability. You know, this patient really looks bad. I think it's at least an 80% probability of a big PE. So that would be one simple answer. But it's interesting that a number of clinical prediction models for PE, one of the items will be PE is the highest probability or the most likely diagnosis, along with some of the more objective things like evidence of venous thrombosis and so forth. So it's a great question. And just to be asking that and trying to think about how to fit it into a decision model, I admire that. Yes, sir.
Hi, Song Chang, and I'll look forward to spending some time with you at lunch today.
Oh, good. Yeah, great.
I really enjoyed your model and your talk. And I'm a primary care doctor. So in my office, I think I use this model with every patient, trying to explain the options and the choices and my recommendations.
Mm-hmm.
And yet the patient will usually respond to me, my neighbor's uncle had a adverse reaction to that drug. So no way I'm taking that, doctor. So the human decision-making, the incredible flawed nature of medical decision-making and weighing of relative risk is really an extraordinary force in the actual practice of medicine. How do you think about factoring in the psychology, and particularly the psychology of patients?
Well, I should turn the question back to you, but I'll struggle with it. Well, I think one of the things is simply to take the time to explain carefully what the stakes are, your judgment about it, and why you think, being very specific about both the patient's potential disease and the potential consequences. I think patient education is probably the answer in any situation where a patient brings what we might consider as somewhat irrational, but yet for them, very rational objection to your program. So how would you Now you answer your own question.
If I had the answer, I'd be up there instead of you. But you know, there's a component of it, not to wax too philosophical, that is rational in the sense that there's a difference, or at least I think about the fact in empathy to my otherwise irrational patients, that there's a difference between actively triggering a side effect when otherwise they were 100% fine versus making doing nothing and being protected. And it's sort of like the ethical decision about the train switch. Like if you could save 10 people by actively sending the train to the other track, would you do it? And that I don't think we give enough respect to the way there's an underlying rationality to the patient's otherwise seemingly irrational position. And I think the more we understand that part, the more effective we're going to be.
Yeah. Well, I mean, there maybe is a little bit of rationality. Anyway, I admire your response. It's been 20 years since I've been at the bedside, so much better than mine.
Dr. Winslow.
Dr. Stocks, my name is Dean Winslow. I do hospital medicine and infectious diseases. And first of all, thank you so much for honoring us by coming back to Stanford and giving the wonderful lecture. Just one real quick comment is about 1973, I was a first or second year medical student at Jefferson in Philadelphia. And one of my mentors, people I really looked up to, name was Joseph Rupp, who was head of endocrinology. And I asked him, I said, if you're going to read a medical journal, like which one would you read? And without hesitation, he said, the Annals of Internal Medicine. And I just want you to know that's still my absolute favorite journal. So thank you.
Well, thank you very much. One of the people who's responsible for Annals' reputation is sitting in the back row, Steve Goodman, who has been one of the statistical editors at Annals since 1988, 85, something like that. And Steve's really quite remarkable. At manuscript conference, we'd go around the room and everybody would give their opinion after a presentation of a study and give their opinion. And Steve would be sitting right to my left and we're going this way. And Steve would be carefully reading it very quickly because he often doesn't do things right on time. And by the time it got to him, he'd come up with a very rational reason for either thinking this is a study we should follow up or not. So, but thanks for the honor to Annals. It was a joy to be an editor of a journal and to have a little bit of the reputation of the journal, rub off on its editor.
Hi, I'm Julie Parsonet, and I'm right here.
Oh, hi, Julie. How are you?
Good to see you.
Yeah.
And I'm an epidemiologist. I talk about pretest probabilities all the time, and I always listen to Steve Goodman. And but I do want to ask about one of the things that's unmentioned here, which is the costs of some of these tests, which is something that we do consider a lot in some of these issues. For instance, you could make the argument based on what I think you presented, I have to think about it, that you should just go to the CT right away if the cost meant nothing. And so how do we integrate cost and also time? So there could be a time lag in getting some of these diagnostic tests that might change some of those probabilities. And so when you're in the doctor who has to make these decisions, how do you then add those particular aspects to how you make those choices?
Well, could you just repeat the first part of the?
The first part was about costs, the cost of testing. How do you consider the cost of testing? Because there may be a more expensive test that'll give you the diagnosis immediately, but you could rule it out.
Okay,
but
got it. So one of the things that CT angio does is to expose you to radiation. And at least for a younger patient, you may be at higher risk of cancer for 60 years. So maybe in a younger person, you'd be a little bit more cautious about exposing them to that radiation without kind of giving it a second thought. But I guess that would be the main way that I would want to respond. That the CT angio, a good test, but it does involve quite a good sized radiation dose, and that really ought to be factored in to the idea of, just do a CT on everybody. It's a great question.
Great. Can I go to Dr. Clever here first? And I have another 150 people watching online. I might get a question, one or two from them as well.
Thanks. Hope this is a fair question. I'm Linda Clever. I wonder if you've had an experience with when Bayes' theorem and your approach didn't work.
It's going to happen, right? Because we're talking about probabilities. But in terms of a specific example, I can't give one. Can you?
You're a
From
rat.
your- from
You're a
your
rat
perspective.
to ask back. But I guess I wonder what's the fallback position? You're going along and you have in mind the formula and the arrows, and it's not working out. How do you rescue your process?
Well, my approach would be to talk to a colleague who knows more about it than I would. I think that's always what we do. And at least for me, one of the tragedies of the pace of patient care, particularly in the outpatient department, is you don't find your colleagues very easily, and they don't want to be interrupted because they've got under time pressure themselves. But I think we don't talk to each other enough. One of the virtues of being in the hospital is a formal way of doing that, but in outpatient, it's a real problem.
I think it always works. I just think we don't have all the data to populate the different probabilities. So as Pedram just said, the house always wins. It's all about probabilities, and the question is, if the model is sound, the question is, do you have enough data to populate all the variables? So I don't know, Linda, that's what I think.
And we're always making bets, right? Sometimes with big stakes, and sometimes we and the patient lose the bet, and hopefully we don't. We can rally at that point.
Great. We'll go to Dr. Schulman and then I'll pop on the line.
Thanks so much for that great talk. I want to actually ask you a different question. You've had all these leadership roles, creating a division here when it didn't exist, being one of the first internal medicine chairs of a department of medicine at a major academic medical center. We're facing an inflection. All of these were new things under conditions of uncertainty. We're facing this huge inflection now with all this new technology, and we have to somehow reinvent that, the field of medicine. Like what do we need to think about as leaders when the uncertainty is about the practice, and how have you seen that leadership kind of challenge evolve?
Well, isn't that the great question of our age in everything, but specifically in medicine? The competition for our time, for our undivided attention. I don't know. I guess in terms of trying to practice at the highest level, despite all these circumstances, my answer to the earlier question would be my answer to yours, which is talk to your colleagues. Don't try to do it on your own if you feel like you're flying a little blind. But what a rough question, my God. Isn't that what you have deans and department chairs to do?
We have a number of questions from online, so I apologize in advance. We probably won't get to all of them, but I'll start with the one that's most upvoted. Dr. Kim, who starts off by saying she agrees with the sentiments of Dr. Winslow mentioned earlier. She asks, thank you so much for this talk and for your work. When trying to apply Bayes' theorem to groups that may not have included randomized controlled trials, how do we adjust for that in older studies that did not include perhaps minority or other populations?
Yeah. So that's a great question. And I've been struggling with that, particularly in preparing for this grand rounds. And it's really hard. And frankly, I don't know. There's, for a particular probability, high or low, of having a serious PE, there's going to be a gap between the two, treatment and not treatment. And a lot of the time, we're used to knowing the effect of not treatment because we do have randomized trials. But here, and my guess is that that gap probably moves up and down the probability scale, that it doesn't really change all that much. But so I've been struggling with this last week trying to get ready for that question. And you can see that I don't really entirely have a satisfactory answer. But I think with a computer, you could quickly do a sensitivity analysis and vary those numbers and see just how much it's actually going to change your decision making. So I think that would probably be the first step.
Another question from Dr. Ash that's getting a lot of upvotes. What a great talk on how to use Bayes. I know you have thought about how to incorporate AI into the learning process. What are your thoughts?
Well, I'm going to spend much of the day discussing this with some people who really know something about it. But in the preface to our book, which was just published, I said, we got to say something about AI. And what eventually I said was, AI is based on a huge data set, like everything on the internet. And there's all kinds of biases in the care of people that are cared for outside the constraints of a study where you want to be really very precise. And so there are going to be biases that in the data that you get by querying everybody that you wouldn't have in a high quality study. And the question is, what are those errors going to lead to? And of course, we don't know at this point, but that's my worry. That's my worry about that intersection. But ask me at the end of the day, because I may have a better answer then.
Great. As we end the hour, I'd like to invite Dr. Scaff to come up and close us out.
Well, I want to thank Dr. Sachs for being with us. I think what you've observed here are two characteristics that I would highlight that all of us should emulate. What Hal has tried to do for us now is to help us to become more precise in our thinking, to help us to move from, what do you think this patient has? Do you really think they have that? Well, probably. And in the studies, and when you and I both say probably, and then we put a number on it, we vary all the way from 0.2 to 0.95. And so your probably and my probably and the patient's probably, which needs to fold in here. So Hal is trying to remind us that when we use language, we're often imprecise. And the best thing we can do is to try to become precise. But I think it was also, if you listen to him over the last few minutes, there was something else that he did that we all have to have the courage to say, and that's, I don't know. I don't know. That field of medicine is one where sometimes we don't know, and we need more data, but we need the empathy and the courage to say we don't know when we're teaching, because there's a whole lot of pressure to never say when you don't know. So I think you saw a model of being able to say, let's be precise, and say, I don't know, when we're not precise. Hal, thank you for coming back. Okay. Oh. I also want to mention that this is a day for teachers, the awards for teachers and awards for mentors. And somebody asked me, what do you remember about your time with Hal Sachs when you were a fellow? Well, there are two things I want to tell you that he did. Sometimes mentors tell you what to do. And Hal Sock said to me, you have to go to the education school and get your PhD. I said, what? But he knew that you couldn't have science applied to a field until you knew the science. And he was insistent upon science in the field. But the other thing about mentoring was he knew that the impact of a mentor depends on the courage of that mentor to be with the mentee when he's needed. And you and I are pulled in so many directions that we may not be with the mentee when he or she is needs us. Well, it reminded me this morning as I was driving in about our first large grant that we wrote together, which we did on a Saturday morning in his front room, in his house. And I just want to give you that example because I think the idea of being in each other's house when we're working with each other as teachers and students is really a model about how closely we want to be with each other, how close we want to be. Yeah, we do need to write that grant. Come over to my house and we'll write it. And so I leave you with that model of every student that you have, be willing to have them at your house at any time and look what can happen. So very good. Thank you all so much for being here.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.